everyone. Welcome to day 4 of the Preemie Power Week. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation, CPBF, and your host for this event. The Preemie Power Week is the second of 2 international live series that CPBF is hosting 2020 in recognition of World Prematurity Day. These educational sessions are in collaboration with the International Family Integrated Care Committee, the Canadian Association of Neonatal Nurses, EFCNI, and GLANS, the Global Alliance for the Newborn Care. For those not familiar with CPBF, we are a charitable organization, and our mission is to support and educate Canadian families of premature babies every step of the way. We believe that through consistent information, access to helpful resources, and peer support inside and outside the NICU, we can empower families, ensuring they are ready to care for their baby. Consistent information is especially important today when we are facing a global pandemic. With educational sessions like this, we intend to bring you the guidance of healthcare professionals and the knowledge gathered by researchers around the world. These are valuable tools to help our community raise awareness and advocate for the well-being of families and their babies. I would like to thank AbbVie for the unrestricted educational grant and Pampers for supporting the Preemie Power Week. And right now, we're going to talk about technological innovations to support parents in the NICU. Parenting a baby in the neonatal intensive care unit is extremely stressful and a challenging experience. Over the past decade, technology has been developed to enable parents to connect with their babies even when they cannot be physically present at the bedside. This presentation will explore how technology might be used to better support parents in the NICU, as well as the challenges that may arise with such innovation. And I have here with me from Montreal, Dr. Jessie Duby, who is a neonatologist at Montreal Children's Hospital and an assistant professor in the Department of Pediatrics at McGill University. She obtained her medical degree at the University of Toronto and a Master of Public Health at the University of Waterloo. Dr. Duby completed her pediatric residency at Cornell Medical Center in New York City and her neonatology fellowship at the Hospital for Sick Children in Toronto. Her academic interests are in global health and family participation in healthcare. In the spring of 2020, she was awarded a technology grant from Pampers Canada and the Canadian Premature Babies Foundation. With this grant, she founded New Connect to virtually link families and their babies in the NICU through video chats and parental voice recordings. Dr. Duby, thank you so much for joining us here today. What a pleasure to have you and learn what you have done to innovate in the NICU during the pandemic.
Thank you so much, Fabiana, and the entire Premature Babies Foundation for giving me this opportunity. Today, I'm going to share with you some examples of how Montreal Children's has used technology to support parents in the NICU and how this might actually be applicable to your units. I want to start off by establishing an understanding of what is the most pressing issue that parents really need support with in the NICU. This past September, the Journal of Perinatology published a review of all studies that explored parental stress in the NICU. The review included 53 studies across 27 countries, and all of the studies used a well-validated tool when interviewing parents called the Parental Stressor Scale. This scale asks parents to evaluate how stressful specific situations are and categorizes them into 4 domains. So infant behavior and appearance might include questions about seeing your baby connected to wires and tubes. Parental role alteration includes items such as feeling unsure of how to help your baby. Sights and sounds are all the alarms and hustle and bustle that's going on in the NICU. And staff behavior and communication includes things like the stress that parents might feel with all of the medical jargon. What was remarkable was that parents from all over the world in just about every study reported the exact same domain as being the most stressful, the parental role alteration. What this tells us is that the area where parents most need support in the NICU is helping them learn what it means to be a parent when their baby is living away from home, enclosed in an incubator under the watchful eye of multiple nurses and doctors? How can we support parents in defining and carving out their essential role in their baby's life? What I find really interesting is that we're very comfortable with technology in the NICU when it comes to the direct medical care of our patients. We love the latest monitors, ventilators, and pumps that help us keep our babies alive. But I want to know if we can also use technology to alleviate the stress that parents feel from their role alteration. We know that parents' stress level and comfort in caring for their child have direct effects on their baby's long-term outcome. And so if we're truly interested in improving the health of our patients, we shouldn't limit our use of technology just to medical care. I have to acknowledge the elephant in the room and admit that it really was COVID-19 which led our unit to start exploring how technology can be used to support our families. While parents not exposed to COVID-19 still have access to their children in the NICU, we bar any parents who have tested positive or are under quarantine from being in the NICU, and all other family members are no longer allowed to visit, even if they're healthy. So we were very fortunate in May of this past year to receive a $25,000 grant from the Canadian Premature Babies Foundation and Pampers for the purpose of using technology to better connect our NICU patients with their families. With this grant, we created the umbrella program called NeoConnect. And there's really been two aspects that have facilitated its success and might be applicable to any unit, any project in any NICU. The first is that we created a multidisciplinary team of doctors, nurse practitioners, bedside nurses, music therapists, NICU managers, and educators to design and implement the program. We also surveyed our current families to ensure that the program was responsive to parental needs. The second aspect that facilitated our success was a bit of an imposed condition. The grant had a very tight timeline. It was awarded in the middle of May and expected to be implemented by the end of July. So because of this short deadline, we knew it was important that we didn't reinvent the wheel. And so we leveraged existing scientific evidence as well as the experience that other units in our hospital had. So with this guiding principle in mind, we started two projects: family voice recordings and family video chats. The idea for the voice recordings as a way to support our parents was based on the evidence about the impact of parents' recorded voices on their baby's health. There's a whole body of literature of the effect of parents' voices on their baby's development, especially for premature babies. But there's also some studies that show similar positive results if the voice is recorded. For example, NICU babies have shown to be less bothered by the alarms and monitors in the NICU if they're listening to recordings of their mother's voice. Premature babies have shown to develop a larger auditory cortex after being exposed to recordings of their mother's voice compared to babies who didn't. And finally, there's a really cool study that tests these pacifiers that play the mother's voice when the baby sucks, and preterm babies who use these pacifiers learned how to feed faster compared to babies who didn't. So with that in mind, we purchased these handheld recorders that are provided to every parent for the duration of their baby's stay in the NICU. We encourage them to read, sing, or talk to their baby, and the recorders are kept at the baby's bedside and played whenever the parents cannot be physically present. And I think everyone in our unit has been remarkably surprised at how our patients calm down once they hear their parents' voices. But we really wanted to see if these recorders helped our parents as much as they were helping our babies. So we've started to survey some of the parents that have participated in the program. And I just wanted to share two quotes that I felt really embody the parents' experience with this project. One parent said, "Recording our voices was a good experience because we know our baby will somehow feel our presence even when we're not around." And another said, "I felt less pain when I would leave my baby, knowing that she would calm down and relax when she heard my voice on the recorder." Out of the two projects we implemented with NeoConnect, this one required the least effort and is probably the easiest to replicate either by an individual parent or an entire NICU. With the disclaimer that I don't have any ties to Sony, we did purchase their recorders for $78 each off of Amazon and have been very pleased with their small size, simplicity, and performance. The recorders are always kept in sandwich bags for infection control reasons, so the nurse can disinfect the bag with a wipe at the beginning of their shift. So for any parents listening to this talk, you could also do the same thing with an old smartphone that you're no longer using if you don't want to purchase a recorder. I think most NICUs would be receptive if you brought in a recording of your voice and asked the nurse to play it when you aren't there. And for NICUs interested in implementing this project, we found that it was very easy to combine the distribution of the recorders with any type of welcome package that you might be providing your families when they're admitted. And on discharge, whoever in your unit is in charge of removing supplies from the room can be assigned to delete the recordings and return the recorders to a central location. The second project was a bit of a bigger beast, but we made use of the experience from another initiative that was taking place in our health center. We're attached to an adult hospital, and so when the COVID-19 pandemic hit, the adult side, like many adult hospitals, closed themselves off completely to all visitors. So they actually quickly bought tablets and introduced an initiative to ensure that families of dying patients could see and talk to their beloved ones through the tablets. What that meant was that the IT support, protocols, and infrastructure for video chatting were already in place, and all we needed to do was adapt it to the NICU context. So we bought the same Samsung tablets, used the same platform that the adults were using, which is just WhatsApp, and we also bought mobile rolling devices that the tablets could plug into. Parents have the opportunity to schedule appointments to video chat with their baby and providers. The times we're using the chats are during medical rounds when we encourage parents to participate. Parents will also schedule the video chats during when a nurse is doing her cares, and they can receive updates at that time. We've also used the chats during family meetings, especially if one parent is able to be physically present while the other one is at home taking care of other children. And then some of our lactation consultants have started to use video chats to guide mothers at home with pumping tricks if they're struggling. Since starting the video chats, we found that at any given time, there's really only a minority of patients' families who make use of the chats because they can't come to the NICU, but those that do often use them daily. While some of our parents use the video chats because of COVID, I think not surprisingly, we've had a whole host of other parents who have difficulty visiting, either to living far away from the hospital or having other competing responsibilities that have made use of the chats. One time that has become very popular is in the immediate hours after a mother gives birth to her premature baby, when she might not be able to visit the NICU because she just had a C-section or has other medical complications. And finally, we found the tablet uniquely helpful for one of our long-term patients' mothers who had severe agoraphobia, limiting her ability to leave her house for any reason. She eventually did start coming to the NICU, and she attributed her ability to see her baby and the NICU through video chats as motivation to overcome her anxiety and visit the NICU. So this project is definitely a bit more effort to start up, as it requires some amount of IT support and administrator support, but it doesn't have to be as big of an endeavor as we've made it. I think you can always start with the lowest hanging fruit, the parents that cannot visit at all. And these are usually only a few select cases, such as being quarantined for COVID. So to target those unique cases, you really would only need one tablet to start. And while tablets can undoubtedly be as expensive as you want, the cheapest ones like Amazon Fire actually cost only around $60. And although I think it is helpful to have a stand for the tablet, again, you may want to pilot the project with a cheap stand that doesn't have all the bells and whistles, but can at least help to embed the project within the culture of your unit. I want to briefly tell you about what we're currently working on for the next steps of NeoConnect, as I think it's another way to support parents with technology, especially during the pandemic. As many NICUs did, we used to hold casual in-person workshops in our parent lounge. But with the COVID pandemic, all of these parent workshops have been canceled. So what we're doing now is we started to create a video library that we're going to upload on all of our tablets and make them available for parents to check out and watch while they're in the NICU. While some of these videos are homemade, many videos to support parents in the NICU are already publicly available, such as the wonderful talks recorded by the Canadian Premature Babies Foundation that are available on their YouTube channel. In Quebec, we're a bit more constrained in picking our videos since it has to be available in both French and English. But for those of you considering buying a tablet for your unit for video chats, I think this is a second purpose of the tablet that can be used to convince your NICU of the value of them. Even without tablets, you can easily make a YouTube channel of all the reputable and publicly available videos for NICU parents and give out that link. Before closing, I do want to highlight some research that has been done elsewhere on other forms of technology to support parents in the NICU. At Northwestern in Chicago, they have created a smartphone application called NICU to Home to help parents prepare for discharge. The app includes education material, a way for parents to track their baby's sleep, diapers, and other activities, and a discharge checklist for items that parents need to complete, like CPR training. Compared to parents who receive the unit's standard discharge education, parents who use this app felt more ready to take their baby home. And the NHS in the UK has designed a video app that allows participating NICUs to send short video clips to parents of significant moments in their baby's life, such as a first feed or a first time being dressed in regular baby clothes. A study of this app found that parents who used the service reported reduced stress and increased emotional closeness with their baby. So in summary, I hope I've demonstrated that technology can be used in creative ways to support parents to be involved in their baby's care in the NICU. Family voice recordings are an easy way to have parents have a profound impact on their baby's physiologic stability and neurodevelopment. And family video chats can break down the physical barrier for parents that cannot visit the NICU. And finally, I think that NeoConnect taught us that for any NICU initiative, a multidisciplinary team with parental input is essential. And really, it's important to leverage existing evidence and expertise when starting anything new in the NICU. Thank you so much, and I'd be happy to take your questions.
Dr. Wood, thank you so much for your presentation, and congratulations on stepping up so quickly in the middle of the pandemic to implement technology in your unit. I know how stressful it was with a very short time limit, but I'm in awe to know what you've done in just a few weeks. It's absolutely amazing. So congratulations to you and your whole team at the hospital. So I have questions to you. And first of all, actually, I want to acknowledge people joining us from Indonesia, Ghana, Halifax, Edmonton, Madrid. We have people from all over the world listening to us right now. Thank you all for joining us. We really appreciate your support. Dr. Duby, what is going to happen with technology after the ICU? After the pandemic, are we still keep using this technology to keep parents connected once the pandemic is over?
I think it's going to be similar to how we're all seeing what technology is going to do for all of us when the pandemic is over. I think Zoom meetings are going to become more of the trend. And similarly, I think technology in the NICU is really here to stay. Again, we're very comfortable with it, with technology when it comes to the medical care we give our patients. So there's no reason that we can't continue to use it to support our parents.
Absolutely. So we have a comment here. Let me see if I can put on our screen. Infection control seemed to be a barrier in our NICU experience, as we were not allowed to bring any electronic devices into or near our baby's space. What precautions are in place to avoid spread of infection to babies? I saw a plastic bag on the recorder. You were told that was not enough and had to do without any electronic interactions. Thanks, Lindsay, for your comment and question.
Yeah, thank you. I'm not sure if my screen is still showing. I mean, we also had to meet with our infection control people to get their approval. And right now, when parents come into the unit with their cell phones, in our unit, they're all required to put their cell phones in a plastic bag because we know cell phones have a lot of bacteria on them. So similarly, our infection control has been willing to allow us to use these recorders as long as they're in a plastic bag and wiped down like any other hospital equipment. And for our tablets, they're encased in a protective cover, and all of these are also wiped down before being used and after being used, the same as you would for any medical equipment.
Absolutely. Dr. B, now we've been talking about technology, keeping parents connect with technology, but I feel that you are a very big advocate to keep parents together with their babies, and the technology is a piece to enhance that connectivity. So parent organizations from all over the world are concerned that technology can substitute parents, especially in units around the world, that parents are not as welcome as our hospitals in Canada. So what piece of advice or recommendation would you have to these units on how to best integrate parents in the ICU with the use of technology?
Yeah, that's a very good point. I think, again, the best is to have the parent right there. And so I think all of the steps to encourage parental visitation and kangaroo care, those all need to be in place before you even think of bringing in technology. Again, this technology is just to supplement for those times that the parent cannot be there. Ideally, we would have live-in rooms in the, I think there's even some units in Europe that do that, where the parents can even move in and be with their baby, because the idea is the parent should be the primary caretaker. The only reason for really instituting this technology is because we're realistic, knowing that parents can't be there 24/7. So really, I think technology should take a backseat to the in-person connection and should only be brought in once there's good visitation policies already in place.
Absolutely. This is so important to keep parents connected all the way. Parents' presence, we know through research how important it is for babies' development, brain development, and parents, especially the parental stress on keeping, babies together so there's no separation. Dr. Duby, I thank you so much for your time today, for sharing your experience, what you've accomplished in the times of the pandemic in your hospital. We are very grateful to have you with us today. Thank you.
Thank you so much. I look forward to hearing the next speakers.
Absolutely. Thank you. And thank you everyone for joining us here today from all over the world. We also have Poland and Brazil online. So thank you so much for joining us here today. We'll take a short break and we'll be back with Dr. Mehaboob Shaik from Edmonton sharing his piece of technology with us today. And in honor of Prematurity Awareness Month, in collaboration with CPBF, Pampers will donate 200,000 diapers to support Canadian families and an ICUs during November and December. And until the end of December, every time you use the hashtag Pampers for Preemies, Pampers will donate one extra diaper to Canadian ICUs through CPBF. I would like to thank AbbVie and Pampers for supporting the Preemie Power Week. It's such a great collaboration that we have, so we can make this week possible. And we are a registered charity, and your donations this week, we go to our COVID care program to provide therapy sessions for NICU families. Please donate on our website, canadianpreemies.org. Together, we can create a brighter future for all NICU families. Our next session starts in just a few moments with Dr. Mehaboob Shaik from Edmonton, talking about Now ICU, connecting moms with babies. So stay with us. We'll be back very shortly. welcome back. This is your second session of the day. And for you who are joining us now, welcome to day 4 of Preemie Power Week. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation, CPBF, and your host for this event. The Preemie Power Week is the second of 2 international live series that CPBF is hosting in 2020 in recognition of World Prematurity Day. These education sessions are in collaboration with the International Family Integrated Care Committee, the Canadian Association of Neonatal Nurses, EFCNI, and GLANS, the Global Alliance for the Newborn Care. For those not familiar with CPBF, we are a charitable organization, and our mission is to support and educate Canadian families of premature babies every step of the way. We believe that through consistent information, access to helpful resources, and peer support inside and outside the NICU, we can empower families, ensuring they are ready to care for their baby. Consistent information is especially important today when we are facing a global pandemic. With educational sessions like this, we intend to bring you the guidance of healthcare professionals and knowledge gathered by researchers around the world. These are valuable tools to help our community raise awareness and advocate for the well-being of families and babies. I'd like to thank AbbVie for the unrestricted educational grant and Pampers for supporting the Preemie Power Week. And right now, we're going to talk about Now ICU, connecting moms with babies. This presentation will highlight the process, timeline, journey of an ICU parent, and family comments about technology. And I have here with me, directly from Edmonton in Canada, Dr. Mehaboob Shaik, who is a neonatologist and passionate about family integrated care. He envisioned and successfully implemented Now ICU project, connecting sick mothers with their sick babies in the NICU at the Misericordia Hospital in 2019. He collaborated with adult mental health and introduced maternal mental health support for mothers with babies in the NICU in 2017. And he also introduced donor human milk bank in NICUs in Edmonton zone in 2012. He encouraged a lot of programs to be created in his unit. And he's also a recipient of the Health Quality Council of Alberta Patient Experience Award. He was nominated Doctor of the Week Alberta Health Services in May 2019 and received the Physician Innovator Award by the Edmonton Zone Medical Association. Dr. Shaik, thank you so much for joining us here today.
Thank you, Fabiana. You can hear me?
I can hear you very well.
Okay.
You can share your screen and guide us through your presentation, and we're going to have a period of Q&A at the end.
Okay. My screen is visible, right?
It's perfect.
Okay, it's perfect. Okay. We are all in different time zones, so I would like to say good day to everyone who is joining for these very interesting presentations that are ongoing. I would like to thank Canadian Premature Babies Foundation, thank Fabiana, Patricia, and all others for inviting me to share our experience in implementing Now ICU initiative at the Misericordia Hospital. We have been connecting mothers in labor and delivery with their babies in neonatal intensive care unit. I heard Dr. Jessica Duby do an excellent presentation prior to me, and I did learn a lot of points from her presentation. I do not have anything to disclose, and I dedicate this presentation to all the mothers who were separated from the babies soon after delivery. The objectives of this presentation are to demonstrate that improving patient experience can start with one patient's feedback and one provider who is listening. The provider could be any healthcare provider who has interest in improving the patient experience. Simple solutions to issues can often be most impactful. That is what we noticed in our Now ICU project. Interventions involving technology do not have to be complex or costly to make a big difference. We didn't spend even a single penny when we implemented this project. We working in neonatology, we all witness almost every day an obstetrical emergency the rough roller coaster road a family goes through. It's our day to day experience that we see the families going to all this turmoil. And soon after delivery, there's a tsunami of emotional reactions that a mother feels when she is suddenly separated from her baby. To just quote a few, there's an abrupt disconnect. The mother feels there's a feeling of emptiness. There's a fear of unknown. The mother asks, "Where is my baby? How is my baby? Is my baby alive? Is my baby breathing?" That fear of unknown is very real. A feeling of powerless, helplessness, and separation distress and anxiety are one of the very important emotional reactions that we routinely see in these parents. During one of my encounters with a mother, one of the mothers told me, I feel I missed so much during my baby's early hours after birth, as I was hospitalized after delivery. Those little things, such as looking into my baby's eyes, hearing my baby's cry, and most importantly, what was happening to my baby in NICU. I wish I could see, could hear, be a part of my care. Those were very, very powerful words for me. So I reflected upon her feedback and went around doing my research. Remember, this was in 2016. Remember, this was before the COVID, when we were all normal. There was no new normal there. We were all in a normal living life. So this was in 2016. When I did internet search, I found that Mount Sinai Hospital was using iPads with great benefits to the parents. So I thought, okay, maybe I can help the parents bond with their babies when both of them are sick and both of them can't be moved to see each other. And I approached our information technology department and the virtual health department. And we all know from our experience how our IT departments are extremely cautious about security, confidentiality, privacy of the involved patients. So it took a long time, a lot of resilience and persuasion, and a lot of thick skin for me from my first thought to roll this program out to make it real. So we started in August 2016, and I had to go up to every level I needed to go in the IT department to get it implemented. And ultimately, in 2019, after 3 years of listening to no to a lot of requests, we finally succeeded. We tried to ask permission to the IT department to use Facebook. They said no, you cannot use. Videos were not allowed, and for we were not allowed to buy our own iPads and use, because again, the privacy and confidentiality issues were always there as big barriers. However, in 2019, after a lot of persuasion, we were given these two units. One is a baby, the smaller one is a baby unit. This is the baby unit. Sorry, this is a mother's unit, and this is the baby unit. So this is extremely portable. It can be put in very small places and can be put very close to the mother, and the mother can see her baby very clearly. This is the baby unit. You can see it has a big table, and it can be rolled right close to the incubator. And this can be kept very close to the baby's face, and the mother can see it. These iPads are customized. They are clean slate. They do not have any applications. They do not record, and it is just live streaming. And the IT department is very, very wanted to use only the stands, because the stands, you can see that the iPads are locked. So they wanted to be very careful about preventing injury. So there was a risk of these iPads falling onto the mother or onto the baby and causing injury. And the IT department did not want that to happen. So the iPads were taken, they were locked, and they were given to us on these mobile carts. And the first time when we used it, The mother who was looking at the baby, she said, "Now I see you." That was a name we caught up. There are so many other terminology that the mothers use. Some of them say, "There you are," and one mother said, "I missed you so much." So these are the first reaction of a mother when she sees her baby for the first time. Remember, both are sick, both are separated, and both are in the same hospital. This technology is used in the hospital and is not. We don't use it outside the hospital. And the process of using this is very simple. You just open up using the password, unlock the iPad, and place a call, and the iPads connect to the other iPad automatically, and you are live streaming. A word of caution: whenever we are live streaming, we put in this telehealth progress caution so that you are live, your voices are being heard by the other people, and you should be very conscious that you are not talking any confidential information of other patients or any of your personal experiences that you want to talk or chat with your colleague when this session is ongoing. So we keep it as soon as the session is started, and one should be aware that you are live streaming both audio and video. And like I told, none of the video that is streamed is recordable. Video is disabled. You can't take photos. That is also disabled. Once the iPad is switched off, there is no way to go back and see what it was about. So there's no storage, there's no memory. And iPads connect to each other and no other device when dialed in using password, which is provided by the Alberta Health Services. Parents can't sign in; they have to request us to sign in. And we don't collect any identifiable information or record anything at all about the patients or the people who are using the iPads. And the unit which we call which we call the mother's unit, it is always facing towards the mother. What is on the iPad is not visible to anyone in a room if she shares the room with some other patients. And to maintain privacy for audio, they can use their own iPads, or if they request, we can provide them with earpads. Again, because the audio is if the earbuds are not used, other people or other patients can hear what we are discussing or talking about the patient's the baby's care with the mothers. We can use this mobile iPads mounted on the cards anywhere in the hospital. We most routinely use it in the recovery room, in the LND, and the postpartum, and we have used it in the adult ICU as well. Once the iPad is switched off, once the use is not there anymore, once the mother is mobile and is able to come and visit her baby in person, we collect the surveys. The surveys are collected, and again, when we collect the surveys, we don't identify. There's no name, there's no address, or any information which can identify the patients or collected in the surveys. The benefits, well, what we noticed was the biggest one was suppression distress between the mothers and the babies. And again, whenever we switch on these iPads, there is a lot of emotion that happens between the mothers and also the NSU nurses who are taking care of the mother and the babies. So there's a lot of emotions. You see so many people crying around once the mother sees the baby and says, "Okay, now I see you." The other one is bonding. Mothers have expressed, it was such a wonderful experience to see my baby. I feel I'm so connected with her as soon as I see the baby. They have reported to me that they find the letdown reflex, and which is really very beneficial for the mother. And we use this technology in daily care team rounds. So the mother is part of the rounds, and whatever we do, we describe it to the mother who is in the L&D, and we actually show her the whole room so that um, she is used to what instruments we are using. She sees how the room is, what the phototherapy units are. She can see the ventilators, the CPAP machines, and the infusion pumps. So once she comes in person, she does not have to be in a shock looking at a baby hooked up to all these pumps and breathing machines. So we do a virtual tour of the room of the baby so that she's used to the baby's room, and we also introduce ourselves to her. So when she comes, she already knows who is the nurse, who is the doctor, and whom she has been talking to, and she is part of our decision making. We ask her whether she needs donated human milk, whether she needs formula, or whether she needs, whether how she's pumping, how we can help her. So this gives a lot of empowerment to the mothers, and the helplessness or the powerlessness that they feel is substantially decreased. And we can use this technology not only in the hospital, but to any other hospital in the province which is under Alberta Health Services. As long as we know the telehealth connection number, we can dial in and connect it with their facility and show it to the and show the mother to the babies. And we have done it in a couple of hospitals where the mother was so sick that she was not able to be transferred to along with the baby, and the baby had to be with us because we were able to provide the level 2 care which was not available in the peripheral hospitals. So it has been a great tool in bonding the parents. Now coming to the parent comments, after, like I told, after every survey, we ask them to document their experience, and it is a bit challenging to go and ask them soon after the sessions, because they're still stressed. We don't want to overly uh, stress them more than what they already are in. The comments that we collected were, and have taken consent from the parents to show their comments. One father said, "I would have to be either with my wife or my baby if this technology was not available. We can now share our feelings together watching our baby in the NICU. I can explain and show her what is told to me in the NICU during my physical visit. We just love it. It is next best to the real experience." The iPads gave us a way to be together even if we weren't in the same room. It was very pleasant experience, especially since I was unable to get out of bed to go to see him. I hope this program gets spread out across the province. I felt relaxed and satisfied that my baby is fine after I saw my baby on iPad. It shortened the distance between the baby and the mother. Very helpful. It was a great tool to see your baby, especially after C-section when it is so difficult to walk for the first 2 days. I felt really good to see my baby. One mother said, felt that the baby was with me. I think these are very powerful statements made by the parents, and it really has made a big impact on our teams who take care of the parents. They feel they are doing a great service by using the iPads, and being a part of the family even before they visit the NICU. The surveys the information that we collect on surveys or the demographic, whether the survey is being done by the parent, by the father or the mother or the grandparent, and the date when the survey was done, whether they would use it again, and whether they would recommend it to their friends or other family members. And we really need to know the feedback the about the clarity of the audio and the video, and whether we were able to maintain confidentiality and privacy of this whole uh, uh, situation when they were using the iPads. And what was the experience? Did they feel good? Did they feel bad? Or did they like it? So this survey, we are still in the process of collecting our data. Once we have it, we'll do a qualitative research analysis, and then we'll be presenting it. And this is the team that were involved in making this project successful. And like Fabiana told, the Health Quality Council of Alberta gave us a patient experience award, as this was found to be very empowering to the parents. Thank you. And I would like to share a video, if Fabiana can upload it, so that we can join the journey of Christian and Quinn.
My name is Kristen Kornelek. I am an RN here at the Misericordia Hospital. I was really sick with a cold and I was really feeling unwell, and I decided to come into the hospital, but it turns out that I had H1N1 and bilateral pneumonia. The birth itself, I vaguely remember being so sick and in such a condition I wasn't actually able to go and see my newborn child. I don't know if it was the first time I saw the iPad and saw her or not, but I distinctly remember seeing her for the first time under lights and being able to hear the nurses and my husband in the background and being able to see her little movements. And for me, with everything that had gone on, it finally felt real. I finally felt connected, because otherwise I never would have had the opportunity to see my child.
Here the mother is able to see the baby and talk to the baby and hear the baby as well, right? And the baby is able to hear, as you said. This is the initial bonding, and when a mother feels, both the mother and the baby, they feel the separation distress. When you separate the mother and the baby, there is a distress, and this technology kind of connects that. It gives them, to feel as if they are in the moment.
It allowed me to bond in some ways, to be able to see my child, to know that she was okay, to know that although I couldn't be there for her, she was cared for, she was loved, she was safe, and that, as soon as I got better, I was going to be able to see her. And so that gave me a sense of comfort and relief.
Dr. Shaik, thank you so much for your presentation. Congratulations on this initiative. It's a very well-deserved award, because we know how hard it is for moms, especially the moms who are sick with the babies, or transfer where the baby gets to another hospital, and she will visit to go and see the baby, be with the baby. So congratulations on that. So what has changed since the beginning of the pandemic in your unit with the technology?
So with the pandemic, the Zoom has come in, and but again, like I told you, this is not a Zoom application. This is a software. It's known as Polycom. It is used by telehealth here at the Alberta Health Services. So with regards to the use of technology, nothing has changed much, because once the patients come in, they're screened, and they are screened for COVID, and most of them are, luckily for us, have been not positive. However, when you see what you saw in the video, the mother, Christine, she herself has H1N1, and she was isolated for 7 days. So what I call it, we use a PPE for the iPad trolley, for that for the mobile iPad. That is a plastic protective envelope. The PPE for the iPad can be used, and we put it on the whole iPad and the mobile card, and leave it in the mother. So because it is a plastic one, the baby is still visible, and the whole iPad and the card is protected. So once it is done, then once it comes out, we do sterilize the whole iPad and the cart. And we left it for 7 days with the mother, who was in complete isolation with H1N1.
Have you used with any patient who have been tested positive with COVID?
Luckily, as I said, we did not have any such patients coming in.
Okay, that's a
Yeah,
very
we're still using it. Yeah, we're still using it routinely in all the other non-COVID patients.
Okay, so we have a comment here. Wow, this is so exciting to see in action, very meaningful to parents of preemies and ill babies in the NICUs. Dr. Shaik, any other unit in Canada interested in following your steps, or other units already following your steps?
Well, as far as I know, some are already interested. What happened was, with Zoom coming in, a lot of iPads had to be given out to different facilities for different reasons. So they're using Zoom, and we are in talks with our family integrated team, 5Care. I see the logo on your website as well. So we are in talks with Karen Benzes and the 5Care team. There's a lot of interest to use it in other areas of the NICU in our province here.
I hope many other units follow your steps. Dr. Shaik, thank you so much for sharing your experience with us here today. We are very grateful that you're able to join us and share what's happening in Edmonton. And we do hope to see you again very shortly.
Thank you, Fabian, and thank you for everyone for having us.
Thank you. And thank you, everyone, for joining the conversation today. We're going to have a short break and be back with Dr. Marsha Campbell from IWK, sharing her experience with technology in the East Coast. And in honor of Prematurity Awareness Month, in collaboration with CPBF, Pampers will donate 200,000 diapers to support Canadian families and NICUs during November and December. And until the end of December, every time you use the hashtag Pampers for Preemies, Pampers will donate one extra diaper to Canadian ICUs through the CPBF. And I would like to thank AbbVie and Pampers for supporting the Preemie Power Week and our team here at CPBF as well. And we are a registered charity, and your donations this week will go to our COVID care program to provide therapy sessions for NICU families. Please donate on our website, canadianpreemies.org, and together we can all create a brighter future for all premature babies and the families. So our next session is starting in just a few minutes with Dr. Marsha Campbell, followed by Jackie Hourigan, a preemie parent. So stay with us. everyone. Welcome back. And if this is your first session of the day, welcome to day 4 of Preemie Power Week. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation, CPBF, and your host for this event. The Preemie Power Week is the second of 2 international live series that CPBF is hosting in 2020 in recognition of World Prematurity Day. These education sessions are in collaboration with the International Family Integrated Care Committee, the Canadian Association of Neonatal Nurses, EFCNI, and GLANCE, the Global Alliance for the Newborn Care. For those not familiar with CPBF, we are a charitable organization, and our mission is to support and educate Canadian families of premature babies every step of the way. We believe that through consistent information, access to helpful resources, and peer support inside and outside the NICU, we can empower families, ensuring they are ready to care for their baby. Consistent information is especially important today when we are facing a global pandemic. With educational sessions like this, we intend to bring you the guidance of healthcare professionals and the knowledge gathered by researchers around the world. These are valuable tools to help our community raise awareness and advocate for the well-being of families and their babies. I would like to thank AbbVie for the unrestricted educational grant and Pampers for supporting the Preemie Power Week. And we are right now continue the conversation of the use of technology in the NICU. And right now is leveraging digital technology to enhance parental presence and involvement in the NICU. Greater parental presence and involvement has been associated with improved outcomes for vulnerable newborns and their families. Yet, the amount of parental engagement varies greatly within and across NICUs. We continue to face challenges in finding optimal ways to enhance parental engagement. During this presentation, we will discuss the development and initial testing and implementation of the SHANICU Home Platform, an evidence-based, parent-targeted, web-based education and support platform aimed to enhance family integration in neonatal care. Implications of COVID-19 pandemic restrictions will also be discussed. And I have here with me joining live from Halifax, Dr. Marsha Campbell, who is a neonatal nurse practitioner and clinician scientist. She's also full professor at the School of Nursing, Faculty of Health at Dalhousie University, and holds cross appointments in the Department of Pediatrics and Psychology and Neuroscience. Her Canada Foundation of Innovation funded research lab, Mom Link, Mechanics, Outcome and Mobilization of Maternally Led Interventions to Improve Newborn Care, is located at IWK Health Center. She primarily holds grants examining maternally led interventions to improve outcomes of medically at-risk newborns, specifically related to pain, stress, and neurodevelopment, as well as novel knowledge synthesis and dissemination methods and digital e-health interventions aimed at enhancing parental engagement. Dr. Campbell, thank you so much for joining us here today. Such a pleasure to have you with us.
Well, thank you, Fabiana. It's just absolutely my honor to be here. And before I begin, I just want to say congratulations to you and your team with this Preemie Power Week. I've been logging in every day and have been so amazed with the content and the quality of the speakers. And as I said, I'm just really thank you for the invitation for me to share in that and tell you today a little bit about our SHANICU Home project and how to leverage technology in the NICU to enhance parental presence and involvement.
Thank you.
Can you hear me and see my slides okay?
Yes, absolutely.
Excellent. So, Fabiana, we've heard so many wonderful talks, and Dr. Carol O'Brien kicked us off this week about the benefits of parental presence. So I'm just going to really, in summary and brief, we know that there are so many benefits for babies with respect to greater parental presence in the NICU, supportive effects of their brain development, decreased stress response, reduced length of stay, improved growth. And, we also know that these benefits aren't isolated just to babies. for their families as well. We know that greater participation in the NICU leads to better well-being for families, reduced stress, anxiety, depression. And while we know a bit about parental presence in the NICU, such as some information related to facilitators or barriers, such as being able to stay close to your baby, or the reduction of light and noise, and looking at ways to reduce restrictions and challenges around having long distances to go between home and hospital. Despite this information, we really have very limited understanding around what type of interventions that we can actually improve the parental presence and involvement in our NICUs, and especially around technology. And so we were really excited in 2017 when we were able to launch our NICU Home Project. And this project really was aimed to develop, refine, test, and implement an interactive e-learning health platform to increase parental presence and involvement of families in the NICU. And we were so thrilled to have this funding through COA, Cisco Canada, and IWK Health Center, with a target not to separate families, but to actually create a way for families to be able to be more actively involved, be more present in the NICU. And so just to sort of point the picture of the context, which you'll see later in the presentation, our project, the NICU Home Project, was aligned in the same timeline or period as we were moving from an open bay unit to a single family room, fully single family room unit. And so what did we do? Well, first we had to see what was out there. What was the quality of existing parent-targeted digital technology in the NICU? And we needed to also ensure that there was ways to have parents and care providers actively involved in every part of our project. So not only did we have parent partners on our research team, care providers, but we actively engaged them in every single step, and you'll see how we did that in a moment. We also needed to figure out where we were starting from, because how could we effective technology, digital technology, without knowing where we were currently with how much the families were present and involved in our NICU, and also the impact of us moving from open bay to single family room. And lastly, we needed to really look at, was this acceptable to families? Was it feasible? How difficult was it to implement these kinds of technologies in the NICU, both from a parent and a care provider perspective? So we started doing a series of studies and reviews, trying to understand what was the impact of digital technology in the NICU, what was currently available to families if they searched on Google or on mobile applications. And not only that, but what were the preferences of families in the NICU to receive this information? So these are some of the students that helped me with these, and really in brief, just to found was there weren't a lot of studies. Those that were small. There were not a lot of robust findings to really help us draw conclusions on the actual impact of these digital technologies. In addition, we found that the online resources were actually rated as low to moderate in quality, and that even the applications, although were better, likely because they were more recent, still were only rating at about moderate scores in terms of content credibility. And so we knew there was lots more we could do to offer to families when we were creating this new platform. So where do we start? Well, also we wanted to think about what would be engaging for families. I think we have to think about that when we employ digital technologies in the NICU. We need to think about initial branding. Was it we wanted to make colors and fonts that were warm and friendly and peaceful. We depicted the tulip as our main logo, and we wanted to do this because we saw that it was a delicate spring flower. We wanted to think that the petals represented the family, baby, and support. So this is sort of was one of the initial branding that we decided upon. We also knew that we wanted to have standardized, evidence-based information that was able to be readily updated, because that was one of the gaps in some of the things that were there. So we actually created a linked library. We ran evidence synthesis. We were able to link this evidence to various parts of the literature within the website, and we're able then to do regular updates so that we could keep the information current, so that families actually had the most up-to-date information. So from the literature and expert feedback, we first thought, okay, we needed to have modules around parents as partners, comforting your baby, the environment, fluids, feeding, nutrition, common NICU conditions, understanding variations in gestational age, and of course, discharge planning or the journey to home. We wanted to do more. We really, again, as I said, we had to feel that parents and care providers really were integral parts. So we reached out to them about the learning and content areas. We did through survey, focus groups, and iterative testing, and I'll tell you just a little bit about that. So we first asked families, what enhances your experience? What makes you be able to be present? And we asked care providers too. And we had almost 80 respondents. And what we found was healthcare providers ranked that the ability for families to be involved and present really ranked the being involved in care was really why they were there. And interesting, although parents ranked that as very important, they identified social support as the greatest predictor of whether they would be present in the NICU. This really told us we had to go back to our planning and think we needed to include ways for families to feel like they were able to have social support, to connect with others. And we also recognize a difference in mother and father. And so we wanted to make sure that our platform was able to provide individualized teaching and sort of targeting both parents. When we asked parents about their learning needs and preferences, what we did this was through focus groups, and we did in-depth analysis, asking families, how do you learn best? What was most helpful? What would you want to know now that you're in the NICU? Tell us about your experience and what we can do to make it better. Well, what families told us that they wanted reliable information, evidence-based, and they want reliable technology, but they never wanted it to replace the face-to-face interactions with healthcare providers. They saw it solely as an augmentation to their care. And they also spoke a lot about the need to have more information about what their role was when they were in the NICU, and also how that role or what they might do for the baby might change based on the baby's gestational age. They also told us very clearly that they wanted more pictures, more videos, more ways to learn rather than just text. We also were able to speak to 23 parents initially, doing very in-depth, think aloud, walking them through the platform, telling us what they saw to understand their user experiences and perceptions. The main strengths they told us was they felt that it was easy to navigate, it was easy and intuitive, it was very appealing to them, and I think what was very exciting for us is they thought that the content was clear, understandable, and very trustworthy because it was obviously evidence-based. So there was weaknesses too, primarily in ways to navigate, ways to log in, ways to integrate into the actual standardized care. And we took all this information and we created this into the next refinement of the platform. So while we were doing all this, we also had to see where we started. Example, we couldn't tell what the effectiveness of the intervention was without knowing where we started. So we did some baseline audits. We asked parents, how much time are you spending in the NICU? What are you doing while you're there? And what factors do you think were associated with you being there? And so what we did, we were able to recruit 105 families. This was during when we were still open bay, and families had to be anticipated to stay over at least 5 days and provide consent. And what we asked them to do was to tell us and fill out daily diaries on how long they were there, what they did when they were there, and then we converted that frequency into minutes and calculated per day so that we could compare whether even families stayed 20 days or 50 days, but what families were doing each day. And what we found was, this was way back in 2018, that about 9 hours a day families were at the bedside. Moms about 8 hours and partners about 4 hours. But interestingly, when we look at what they were doing when they're there, so this roll, if you start on your upper right in the yellow, it talks about that moms spent about 16% of their time while they were in the NICU providing skin to skin, and about 20% of their time either green, singing, talking, reading, purple, holding clothes, doing other activities, feeding, bathing, pumping, diaper changes, and about 16% of the time they weren't really involved in any type of care for their baby. Interestingly, when we looked at the partner now in the intercircle with the same color scheme, we see that they provided a little bit less skin-to-skin contact, a little bit less pink in the other, and about the same amount of singing, talking, reading, or holding clothes. But it became very obvious to us that families and partners were about almost half the time they were present, but they weren't actually involved in activity. And when we looked at that data a little bit more, this is a recent study that we've just reported using the same data. And what we found was, it wasn't just father's presence in the NICU, it was actually how involved they were in the NICU that was actually associated. So greater father involvement was associated with reduced risk of symptoms of postpartum depression in mothers. So this really emphasized the importance of ensuring that whatever we created in the NICU had to target both mothers and dads, and really reiterated the important talk that Dr. Feely talked about yesterday about the importance of fathers. So then we moved to the single family room. Not surprising, this is some pictures of our new single family room. We have bed space, we have bathrooms and showers in every room, lots of space for families. And we wanted to make sure that we understood what that change did to our baseline before we were able to evaluate our technology. So we use the same type of treatment eligibility criteria, and we were able to recruit 74 families, 36 to open bay, 38 to single family room, using the same methods of having them do daily diaries about their presence and involvement. And what we found, not surprisingly, was that just having a single room, this is before they had the technology, we saw almost 10 hours more than families that mothers stayed, and about 12 hours more that dads stayed, or partners. Now, this is a very busy slide, and I just want to really point out to you that if you think about all the colors other than the green, that's what families were doing. So what we found was there was really very little difference in the amount of time that families spent in the open bay cohort or the single family room being actively involved with their baby's care. And yet they were there so much more. So there was a tremendous amount of time that families weren't actually actively engaged, even though they were there more. So what this told us was that while there was a significant variation on whether families might be present in a single family room or an open bay, we didn't see that same change in how involved they were. So it really meant that we needed to target using these interventions on having families feel entirely integrated and promoting active involvement while they're there. So we took all this information and we put it into our revised ShaneIQ Home. This is our login page. You can see we actually made refinements so that when they logged into a family, so a baby, they were able to differentiate whether it's mom, dad, or grandmom. And so that we were able to do some targeted teaching and also understand where they were going and what they were doing. We wanted to make sure that the content was readily available on any type of device, so we spent a lot of time making sure that they could access it on an iPad, on a phone, on a home computer, and so that they would have the same experience. We refined, we redid our best evidence synthesis, we took all the information around from the parent groups, and we did some revisions so that our latest learns are really parents as partners, comforting your baby, again, creating a nurturing environment, feeding and nutrition, and NICU conditions, and gestational milestones in developmental care. We also changed a lot on our navigation, so families wanted different ways to navigate through. So we had benefits, so we could either navigate into the bottom, forward or backwards on the pages. They could have left-hand side bars to show their progress and how they were doing. We incorporated 14 videos, things on sleep, going home, transferring your baby skin to skin. And what was really exciting is we used families who are currently in the NICU to help us create this. We have professional photographers and videographers, but we used families so that the families using this could see themselves in these videos. We also honed in and made some changes so that it was really easy, much easier for families to track what they were doing while they were there, providing comfort, bathing, etc. They could track what they wanted with their babies with respect to growth. We also did some refinement in our discharge summary in that we wanted to make, this was actually something the staff make it very easy. So if people wanted to do all their discharge plans virtually using all the pathways, we could just actually print that report and have moms and dads and the healthcare provider sign that and have that part of the chart, trying to increase use in a standardized form. Families were able to ask questions to healthcare providers. Again, we've had over a 700 photo inventory of families doing different things to show how they can be involved. Families told us they like the idea of graphic design too, to actually show them, to walk through, give them visuals about what they might be able to do as being able to be fully integrated in care. We did staff videos. We did videos to help families log in. We have a back-end portal so that it's really easy as part of our admission process. Families are offered, and then they are added to the back end by the ward clerks, and they are able to access fully the platform. We're able to do some analytics to see where we can improve, where families are going, what they need. And in our first feedbacks, what we found was we really targeted the discharge pathway first, and we found that of the 318 people who responded, really all but 2% felt that it was very useful, and also the 35 now that we've just started looking at the learning chapters also strongly agree that this is very helpful to them. But then COVID hit. And so this really meant that it was difficult for us to approach families. Most of the research was stopped, and we couldn't really continue with sort of the impact piece of this, but we really wanted to have it readily available, especially from the virtual technology piece. So fortunately, we were able to pivot slightly and receive additional fundings from within a response to COVID-19, in which we were able to try to look at instituting clinical virtual care pathways so that staff could ensure that whether families, only one family member was in the unit, they would be able to transparently reach all families members with the use of the virtual information. We were able to do a needs assessment with families and in-depth interviews. And really what they told us is that, again, COVID, this is not surprising. They felt disconnected. Family and healthcare providers told us they felt that family integrated care was going backwards. Families felt broken. Families needed a way to move forward. And so what we are working on now is a way to be able to audit and have every healthcare provider ensure that all families are able to be onboarded, either provided virtual teleconferencing systems within the unit, either on an iPad, the family's personal devices, or in telecommunication systems in the actual rooms, that moms and dads would have access at home, and in the hospital. They could share information, and this would also help with discharge teaching. So we're moving forward to evaluate this, wanting to ensure that all families are offered. And so in the end, I just want to summarize that the SHANICU home is about having families and present in the unit, actively involved in the unit, providing them the support and connection they need to families and healthcare providers, and the education they need to ensure optimal outcomes. We are actively also lobbying, and this is just an information for those who are also lobbying around trying to ensure that families are not separated, either that they still are or in a second wave. And this is just recommendations. We are very excited to be able to include in this recommendations to provincial and federal funding about supporting mental health of Canada's and having families of vulnerable neonates on this list, as well as other groups. So I will say special thanks to all the people and all the funders who have helped with this project. And thank you to the Canadian Premature Baby Foundation for inviting me today, and all you do to support Canadian families.
Dr. Campbell, thank you so much for teaching us, showing what you're doing at your unit. You have a wonderful unit with really supportive families who stay together. When I visited your unit a few years ago, I was blown away to see there was a bathroom with a shower inside each room. So that is incredible. So my first question to you is, with the pandemic and extended family not being able to come to the unit, or siblings, how is the SHANICU supporting families that way?
Yeah, so that's a great question, Fabiana. We're lobbying strongly to have siblings come. I think what families tell us is what is helpful is all of the pictures and the videos, so that that will be able to, even children who may not be able to see what it's like in the NICU. They can see pictures, they can see things about what their baby looks like, and also, again, the virtual teleconferencing, the secure system, allows children to see their siblings.
So let's talk about the survey that we are disseminated across Canada to understand parents' experience in the NICU during COVID. We just shared the link on our comments. We are hoping to have a lot of families and healthcare professionals helping us with that survey, because it's very important to understand the impact of COVID, because not all NICUs have what you have at IWK. So tell us about the survey.
Yeah, so thanks, Fabiana. So what happened was, when we started to look at the impact just locally of the pandemic, it became very clear to us that we don't know what's happening across the country. And when I talk about lobbying government, lobbying decision makers to try to ensure that NICU families are not part of those same universal restrictions, because they should be considered caregivers and able to be always with their babies, what happened is are asking us, well, what's the proof? What's happening across the country? How can we do national decision making if we don't know? So our national survey is really looking at what was the impact to families. And also there is a very strong mandate in that too, about ways to make it better, including technology that's acceptable to them. So again, we know that there's been other surveys done primarily looking at healthcare providers. This is very much directed at families. So if you've been a family or you know of someone who was in any Canadian NICU since March 2020, please, or currently, please go to the link and fill it out. We want to hear from you. We need that. Not only I may not help you at this moment, but it will help others and it'll help to inform decisions going forward.
Absolutely, because the pandemic, it doesn't seem to be over in the next few weeks. So we really need that data collected to act and keep families together across the country. Dr. Marsha Campbell, thank you so much for joining us here today. What a pleasure talking to you. I'm so grateful that you took the time to share what is happening at IWK and your experience with SHANICU. So thank you.
Thank you, Fabiana. Always such a pleasure.
Thank you. And for all of you joining us here today, thank you for staying with us and participating in this conversation. We're going to have a short break and come back with Jack Hourigan, who is a preemie mother, talking about connecting and communicating well with preemie parents virtually and bedside. And in honor of Prematurity Awareness Month, in collaboration with CPBF, Pampers will donate 200,000 diapers to support Canadian families and ICUs during November and December. Until the end of December, every time you use the hashtag Pampers for Preemies, Pampers will donate one extra diaper to Canadian ICUs through CPBF. And I would like to thank AbbVie and Pampers for supporting the Preemie Power Week. We are a registered charity, and your donations this week will go to our COVID care program to provide therapy sessions for NICU families. Please donate on our website, canadianpreemies.org. Together, we can create a brighter future for all NICU families. So stay with us. We're going to be back in very short time with Jack Hourigan. Thank you. Welcome back and welcome to the Preemie Power Week, Day 4, if you're just joining us now. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation, CPBF, and your host for this event. The Preemie Power Week is the second of two international live series that the CPBF is hosting in 2020 in recognition of World Prematurity Day. These educational sessions are in collaboration with the International Family Integrated Care Committee, the Canadian Association of Neonatal Nurses, EFCNI, and GLANCE, the Global Alliance for the Newborn Care. For those not familiar with CPBF, we are a charitable organization, and our mission is to support and educate Canadian families of premature babies every step of the way. We believe that through consistent information, access to helpful resources, and peer support inside and outside the NICU, we can empower families, ensuring they are ready to care for their baby. Consistent information is especially important today when we are facing a global pandemic. With educational sessions like this, we intend to bring you the guidance of healthcare professionals and the knowledge gathered by researchers around the world. These are valuable tools to help our community raise awareness and advocate for the well-being of families and their babies. I'd like to thank AbbVie for the unrestricted educational grant and Pampers for supporting the Preemie Power Week. And right now we're going to talk about connecting and communicating well with Preemie parents virtually and the bedside. Jack Hourigan, veteran ICU, FICARE parent, and communication specialist at the Sway Partners, will discuss the essential role that parents play as partners in the circle of care, especially during times of COVID-19. Strategies for engagement, wellness, and virtual communication with Preemie families will be explored followed by a live Q&A. Jack Hourigan is specialized in building connection. As a professionally trained improviser, writer, and former television host, she combines her lived experience as a Preemie parent with her communications expertise to integrate teams, bring awareness, and enhance healthcare delivery. She volunteers with the Canadian Premature Babies Foundation, works with It Doesn't Have to Hurt pain management education, and other initiatives which enhance the lives of patients, families, and healthcare professionals. Jack, thank you so much for joining me here today. What a pleasure to see you and to have you here today.
Thank you for having me. I actually can't see you. I just see my screen. But other than that, it's awesome. It was so great to listen to Marsha speak too and hear about what's going on there. And yes, I'd like to fly all the way to Halifax and just have a shower in their unit because it's awesome.
So yeah, Jack, your presentation is on screen. You can start and we have a Q&A at the end.
Sounds great. Okay, so as Fabi said, my name is Jack Hourigan, and I am a mom of a premature baby. My daughter Tess, here she is on the screen, is now 9, but this was her in 2011. She was born at Mount Sinai, and she was 27 weeks. And I was terrified. I was absolutely terrified and didn't know anything about having a premature baby, like most people who have babies too soon. But what changed for me was something called family integrated care, where I became an active role in my daughter's circle of care, and I had a purpose every day. The importance of being there and being present in the unit for my daughter, for my own mental health, for my family, and learning about how to be a better parent after I left the unit was so helpful to me. I'm sure you've heard all about family integrated care, but for me, what was really important was being there and learning about my daughter and being the person who knew her very well. There was a period where we were close to the end of our time at Mount Sinai, and my daughter, out of the blue, kept having a lot of cluster spells, and we couldn't figure out why. So that was delaying our leaving the hospital. And because I was doing family integrated care and charting her in and outtakes all day, and because I was at rounds every day, and because I felt comfortable and safe with the team to ask questions and put my input in at rounds, I discovered that I thought it was the iron she was getting orally that was causing these spells. And I brought it up with the nurse practitioner. So afterwards, she said, well, bring it up at rounds. And we did. And they said, okay, go downstairs and maybe we'll get the cherry flavored Palafor, the iron for her, and try that instead, because my daughter likes that at home. Well, we did. It changed everything. And she stopped having the spells, and we were home 2 days later. So the integration of parents and families as critical parts of the team is so important. And being present as a provider and an advocate and a parent, as opposed to being a visitor, is so important, especially in times of COVID like now. So we've all heard about the patient and family-centered care principles: respect and dignity, participation, information, and collaboration. But like I said, Phi Care goes one step further, and it really becomes that the parents are true partners in the baby's care. And it really changed the way my time at the NICU was with my daughter, and it also changed other people's after me. I became a parent liaison in the hospital at Sinai afterwards, and peer support was so important for people who have been there to help others. So having that network, or having the network with the Canadian Premature Baby Foundation online right now, is critical. Just like Dr. Marsha was saying earlier about keeping that connection and making sure that people feel heard and connected and have a network of support for themselves, for their mental health, and for stressors in these situations. So when you're partnering with patients and families, whether it's virtually or in real life, there's a lot of things. My background is Second City and improv and theater. So there's a lot of things with your body and your voice and ways to communicate that you may not have thought about before. So I'm just going to go through a few things that might help you to interact with patients and families better. And if you are a patient or family person, how to interact with the team. So keep in mind that eye contact is really important. Now, eye contact is really important in person when you're seeing each other, but in times like these, eye contact by looking at your camera and trying to connect that way is equally as important. Seems weird at first that I'm talking to a green dot, but as they taught us in television many years ago, talking to the green dot is like talking to somebody on the other side of the camera who is a friend or someone that you want to connect with. So finding that connection and having that partnership with patients and families starts with really being present and connecting through eye contact or connection this way. We've all heard about rephrasing and repeating back information to see how patients and families are hearing it and how it's landing. That's so important. As a NICU mom myself, I was so overwhelmed and there was too many things coming at me at once. So having someone really be there and be present, and for me to reiterate back what I didn't know so that they could help me through the journey, was really important. Also, roadmaps. I loved structure. I loved the structure of family integrated care. When I did not have that before at the beginning of my stay in the NICU, I felt lost like a cork in the ocean. But when I had a structure and I knew what was going to happen next, as much as you can in a NICU, it really gave me some grounding. It gave me peace and calm, and getting information and a roadmap in small chunks was really important for me. It's so overwhelming, so breaking it down into small pieces. We talked about, eye contact and being virtual, but reading the room, as in body language, tone of voice, if people are looking away, and reading the Zoom is also equally as important. So in addition to talking to the camera, but looking at the Zoom, if it's a group, if you're hosting a group, or if you are doing one-on-one with a patient or family, being aware of nuances of the body, being aware of how people are holding their head, being aware of tension in their body, just seeing the whole person inside and out. And active listening. That can be by seeing the person's body, but also really engaging and repeating back phrases or mirroring body language and a couple of words here and there so that you're connected to the person. When I was in the unit, the most important thing for me was to hear people say please and thank you to me, that I was part of something, that I wanted to connect. When someone thanked me for doing something with my child, it was wonderful. Or giving compliments to feel connected to the staff and feel like I was valued was really important for me. Also smiling. Whether it's just eye contact and a smile and looking up, whether you are present in the unit or doing it online, smiling and feeling connected to someone is really important. If you're worried about a patient or family and you don't know what's going on, asking an open-ended question as opposed to a yes or no question is really important. A question like, tell me more or help me understand, as opposed to a yes or no. Are you eating? No. Tell me more about your eating habits. Tell me when you're sleeping. Explain to me how those kind of things will draw out more information. Short questions give long answers, which give you information to help and connect with each other. And as I said before about encouraging peer-to-peer support online or in person, so important to connect with someone who actually gets it. Now let's talk about a little bit about if you are doing projects. I know it might be hard to do right now in this climate, but when you are including patients and families in projects, it's so important to include them from the beginning, not at the end when they have to pick out the wallpaper or the shower head in the unit. Having buy-in and ownership from the beginning that you're all in it together and everybody's voice matters is really important. Nowadays, there's a lot more options for meeting virtually. So giving options for people to participate in research or in committees or online peer-to-peer support is so important. These times are tough. It's hard, and we're all going through struggles. So valuing people's time and understanding that everybody's at home right now, so the balance is a little bit shifted. And being aware of triggers, from the unit or certain words or things that might bring back feelings is important. So making sure that people in your committees, or if you're working in groups and trying to do some sort of a research project, that you check in with the patients and families and make sure things are landing okay and they're feeling okay. And that way it brings in a lot of diverse perspectives. You don't want everybody having the same experience. You want to learn from everybody and really become a team so that you can make the best possible changes and help the patients and families. This was a course that I did. I was at a conference and I saw a doctor speak about this called Vital Talk and this concept called nurse. And I have nothing to do with them, but I will say it was really beneficial for me. So if you want to Google it later. It's just giving role play and words and how to speak to patients and families. Naming it is the first one in the nurse. Understanding, respecting, supporting, and exploring. So when I was in the unit, there was a little bit of a mishap that happened with my daughter, and we had a family meeting. And I was so fortunate that the doctor who started the family meeting said to me, I'm sorry this happened. How can we make this situation better? We are here to help you. And that was a game changer for me. That changed everything. I felt heard, I felt respected, I felt like we could work together instead of me losing it and being terrified and scared. So words matter, grounding matters, and finding ways to connect with patients and families and understand where they're coming from is simply about how you word something. So if you can, check out Vital Talk. It's a great program. Let's talk about how we show up. These are silly times in the world right now, and showing up, how you show up as a caregiver, as a clinician, as a patient, as a family member is so important. So mindfulness, breathing, taking breaks, doing things for yourself and self-care is so important. Journaling your feelings, knowing when things are getting too much, and actually pressing the pause button and stepping away. Whether you are helping a family or you are a family member yourself. It sounds silly, but even on Zoom, I encourage clients when we are on long calls to take breaks and open a window, get some fresh air, stick your head out the window, or go outside and walk around the block. Just getting some perspective, sunshine on your face, and air is so important. Another great way to show up for patients and families is to debrief first. When things go awry, being able to, in a healthy way, talk with your team about what happened and how you can change it for the future. And really being honest and having a safe place where you can discuss that together and having brave conversations with each other to make things better. Another way is if you are, like I said before, on virtual, connecting through the camera, really making sure that you're talking to your colleagues or patients and families directly, and you're present with nothing else distracting you outside. And I heard something yesterday. I was giving a webinar, and a wonderful woman who is a CFO of a company, I found out she was a premature baby. And she started talking about her life and her job, and it just came up out of nowhere. And I was so taken aback by how she spoke and the impact of being a premature baby and how it impacts her as a leader today. And one of the things she said was, sometimes I get ants in my head. Ants were thoughts. I can't even remember what they stand for, but incoming negative thoughts, a negative thought coming in, ants in your head, and how to get rid of that. Positive self-talk, talking yourself through something and breathing. These are difficult times. There's a lot of pressure on healthcare workers, on the system, on everybody being on top of each other and at home, and most importantly, the unknowns. So being good to yourself and trying to internalize that is so important. So you are all superheroes. Thank you for the work you do. It's incredible. I am so grateful. And I want to know from you, if you want to interact later or just to reflect on this later in the day, think about what your superpowers are. When you have a healthcare team, what do you bring to the table? Everybody has their own superpowers. Some people may be great in a crisis. Some people may use humor to deflect. Some people may be great at bringing the room down and being calm. Some people may be great at putting in an IV when someone else is stressed. Being aware of the superpowers on your team and how you can use them together as a unit and how you can use them to make each other feel safe and comfortable and have each other's back. These are amazing times, and being able to use your superpowers and really connect with other people makes some of these hard days a little bit less hard. So let's look at this last one here. This is a picture of my daughter Tess. Like I said at the beginning, this is her Preemie week picture from last year, actually. I love her hat. But when I look at this picture, it's on my screensaver. And I encourage you all to take a look at your phone right now and look at your screensaver. The most important people or thing to you is likely on that. And when you are feeling overwhelmed and when you need to connect and when you really need to know what matters, take a look at that. And remember that everyone around you is human like you, whether they are patients and family in the unit or your family at home. Everybody has a screensaver, and everybody is human, and everybody has people they love and protect. So when things go awry, 9 times out of 10, it's just to protect people they love. So keep that in mind, and also remember that your screensaver is something for you to reflect on when you need a moment of calm and peace to bring you grounded. The last thing I'll say about grounding is doing body scans. When you feel your body and know your body, you know you're tense and you need to release. Exercises to do that are great. Breathing, diaphragmatic breathing, box breathing, all of the above. So I hope some of this was helpful. I'm here to answer a few questions if anybody has any, if anybody's out there. I don't know. I feel like I'm just talking to a green dot right now. So I am going to try and not share my screen.
Yay, so no green dot anymore.
All right. My screen, I don't know how to undo this, Fabi, but maybe you can bring me back to you and I together. Okay, here we go.
Just stop sharing.
Stop sharing, stop sharing. Okay. I'm an old lady when it comes to technology. Is it stop sharing?
Yes, on our side. Can you see me?
I can see you. So are we good to go?
Yeah, so all good. So Jack, thank you so much for your presentation, for taking the time to talk to us today. You are not my screensaver, but you were my saver when I was in the ICU. Jack was the first parent partner in Mount Sinai Hospital as part of the research study for Phi Care. And I was one of the lucky ones to have Jack on my bedside. And to this day, I remember one day I was having a terrible day on a little waiting room on the old unit, and I was crying because I was tired of the ICU. And Jack came to me, and I remember you said, you hit that wall, didn't you? I was like crying, but it was such an important moment for me to have someone who understood the journey and where I was at the journey and how exhausted I was after more than 100 days in the ICU. And that peer support is so very important for families in the ICU. So that leads to my question to you. You know what is happening in the ICUs right now with parent separation, no peer supporting person in the hospitals. What is your take on it, Jack?
Wow. Well, there's so many layers to this, but I will say, because both of you and I have got peer support and know how important it is. Peer support, virtual or together, is important, but also being in the unit and being present as a family with your partner to be there for your baby is so important. I can't imagine going through this without being with my child and having the support needed. So, the Facebook page that you guys do and the peer support is so important for that. And luckily, having technology in the NICU now to connect people and have that feeling where someone gets it when you do hit the wall and you're just like, I can't do this anymore. That feeling of complete exhaustion and not knowing what to do next and having someone just to guide you over that next little hump is so important. There's a lot going on in units right now, and I'm a big advocate for parents being present. They are not visitors. I know this is hard to navigate, but these are things that will affect the baby and the parents for the rest of their lives. So having them together as a unit and having support is really important.
Absolutely. But I also want to let people know that every Wednesday, 1 p.m. Eastern Time, Kate Robson, who is also a mom of preemies and a therapist, is hosting a real-time peer support group. And you can join by joining the Canadian Preemie Parent Support Network, which is our private Facebook group. So at least you can have those conversations with families, checking in, see how you're doing, whether you are in the ICU or home after discharge, because it's a lot of isolation, especially at this time when we already have to stay home. You cannot access resources outside the house. Everything is virtually. So it's very important that we stay connected somehow during this time. So Jack, a question for you, because we know there's a lot of follow-up appointments happening online at the moment. And some diagnoses are being done virtually. So how can clinicians break news, difficult news for families virtually?
That is a really great question. So some of the things I mentioned in the presentation about connecting, staying present, tone of voice is really important. I also have a little video of how to set up your space so it's professional, and I can give you the link to that. But, mirroring, active listening, even though you're not in the same room, but doing it virtually, when people hear that type of news, they need to feel supported. So really being aware of their body language, like I said earlier, reading the Zoom, actually hearing if it's landing. This is, these are difficult conversations. So the other thing I would say to clinicians too is to be able to say, how is this landing for you? How are you feeling right now? And open-ended questions to get more information to gauge what's happening, because it's hard in two-dimensional to really know what's going on with someone, especially when they're getting diagnoses or they're confused. So listening, connection, reading the Zoom, follow-up is really important. You may have a full conversation and think it went one way, and then find out later that it didn't land anywhere near what you thought. So coming back to it and revisiting it and making a plan, an action plan. I'm going to check in with you in 24 hours or come back to it is really important. But tone of voice is important and body language.
Absolutely. So very important. Jack, we also share your website because you have a lot of tips for families who are home right now during COVID. Can you talk a little bit about the resource that you made available there?
Yeah, and it's frozen right now because we had too many videos on our site at the moment. So I will re-pull it back up. But I had a lot of educational resources and videos and things for parents at home when the first wave of COVID hit. So we're going to put it back up on our website for later as well. I think we might be going in that direction again, and knock on some wood that we're not going there. But also on the website, there's a couple of podcasts about storytelling and the importance of storytelling and telling your story as a patient or a clinician, and the timing of that, and knowing how to tell your story and why, as well as virtually connecting and setting up your space and the camera angles and things like that. So technical things as well to share with sites or with to get a Zoom going in a productive way, especially if you're doing rounds that way or whatever it is.
Absolutely. And Jack also just finished working with us on the video series that we just launched this week. Welcome to the NICU. What can you do in an ICU? And feeding your baby the NICU is all evidence-based. And Jack put her heads together with a lot of doctors from across Canada to really bring that information. It's four short videos with all that you need to know when you're first coming to the NICU. So Jack, thank you so much for joining us here today, for sharing your experience with prematurity, but also to share your professional expertise with healthcare professionals across the country and across the world. We have an international audience here. We are so grateful to you, and I hope I will see you soon in person.
I hope so too. I want to give you a big hug. Thank you to all of you out there, all of you healthcare workers, parents, everybody. Happy Preemie week to you all, and congratulations to you, Fabiana. That the website has so much information now, and this is such a wonderful resource, and all the things you're doing at the Canadian Premature Babies Foundation for patients and families, and it's amazing. Great resources. I bow down to you in my purple Preemie shirt.
It's all teamwork.
Ciao, Bella.
Thank you.
Thank you.
And thank you all of you for joining us from all over the world. It's such a very important week for us to bring our community together, all stakeholders, our community, our doctors and nurses. We are so grateful to all the work that you do every day in the units, and for all the parents who have been joining us and sharing their stories and their experiences. We are so grateful to all of you. And in honor of Prematurity Awareness Month, in collaboration with CPBF, Pampers will donate 200,000 diapers to support Canadian families and NICUs during November and December. Until the end of December, every time you use the hashtag Pampers for Preemies, Pampers will donate one extra diaper to Canadian NICUs through CPBF. And I would like to thank AbbVie and Pampers for supporting the Preemie Power Week. And obviously thank our CPBF team for working so hard to make it this week happen, especially Renata and Patricia, who coordinate this project with me. And we are a registered charity, and your donations this week will go to our COVID care program to provide therapy sessions for NICU families. Please donate on our website, canadianpreemies.org. Together we can create a brighter future for all NICU families. And tomorrow is our last day of the Preemie Power Week. And I have an incredible lineup of speakers. Dr. Pablo Duran is joining us for Uruguay. He is from the World Health Organization, and he's talking about sustaining essential care for very small and preterm newborns and challenges within the COVID-19 pandemic. He starts at 12 p.m. Eastern Time. And followed his presentation, I will have Claire Osechuk and Claire Dion Fletcher. They are hospitalist midwives, and they're going to talk about improving Indigenous cultural safety in the NICUs across Canada. This is such an important topic for us, and I hope you all join us tomorrow. And to finish our week, wrapping up Preemie Power Week, I have the honor to have here with me Dr. Shu Lee, talking about the future of neonatology. I absolutely love Dr. Shu Lee, and I'm sure we'll love his talk as well. So thank you, and join us tomorrow, 12 p.m. Eastern Time, here on Facebook or YouTube. We are so grateful to have all of you during this week. Thank you.